It is my pleasure to welcome Dr. Bilger, an interventional cardiologist at the University of Bern. Today we'll be discussing his JACC interventions manuscript, reporting the incidence, predictors, and clinical outcomes of hemodynamic valve deterioration after TAVR. Dr. Pilgrim, thank you so much for taking the time to join us and share your expertise.
Thanks a lot for having me.
First, can you give us a background about the topic, the questions that you and the team aim to address, and the population that you studied?
So exactly, so data on durability of transcatheter heart valves is scarce, right? And there are different definitions of hemodynamic um, of structural valve deterioration or hemodynamic valve deterioration. And data that is available is also limited by the competing risk of mortality. So what we wanted actually to do is we wanted to analyze the incidence, the predictors, and the clinical outcomes of patients with hemodynamic valve deterioration after transcatheter aortic valve replacement according to the VARC-3 definition. That's what we want to do. Yeah.
Yeah, perfect. And what the population that you included?
So we analyzed more than 2,400 patients from a single center registry. All of these patients did have echocardiographic evaluation at baseline, so at discharge after transcatheter aortic valve replacement, and at least 90 days after TAVI. The median duration of follow-up in this population was a little bit more than 1 year, and as long as 10 years after TAVI.
Perfect. And what did you guys find?
So what we found was that the incidence of hemodynamic valve deterioration was approximately 2% at 1 year after TAVI, approximately 10% at 5 years, and 25% 10 years after transcatheter aortic valve implantation. What was interesting also is that the predominant mode of valve failure was transprothetic aortic regurgitation rather than stenosis. So more than 80% of patients presented with regurgitation rather than stenosis. And we also assessed predictors of hemodynamic valve deterioration, and we identified aortovalvular calcium volume as a predictor of valve deterioration. So patients with more calcium volume in the aortovalvular complex did have an increased risk of hemodynamic valve deterioration, but also residual aortic regurgitation at discharge was identified as a predictor of hemodynamic valve deterioration. Surprisingly, also patients that were discharged on oral anticoagulation after TAVR were at an increased risk of hemodynamic valve deterioration. What we also did do is we also performed a case control matched analysis of patients that did have hemodynamic valve deterioration compared to those with no hemodynamic valve deterioration. And what we found was, unsurprisingly, that patients that did have hemodynamic valve deterioration had a 4 to 5 fold increased risk of repeat intervention, right? But rates of mortality or cardiovascular death were actually comparable between patients with hemodynamic valve deterioration and those without.
Perfect. Thank you so much. I think that's a very nice summary that goes over all the results. What's your takeaway message for the listeners from this paper, and how do you think we should move forward given these results?
I think several aspects are important. I think one thing is, and this is probably clear. I think all patients after bioprosthetic valve implantation need um, regular clinical and echocardiographic follow-up. So we don't want to miss structural valve deterioration, hemodynamic valve deterioration. We do want to identify patients that may need repeat intervention. And then second, maybe there are also strategies to actually decrease the risk or increase the durability of transcatheter heart valves. Maybe there are strategies to prevent hemodynamic valve deterioration or just delay it. And I mean, there are several possibilities, and these are under study. So maybe we need to have an optimization of the peri-procedural results, so optimal device expansion, but probably also not overexpansion of the transcatheter heart valve. This may be important, and maybe also the height of implantation may play a role in that regard. Maybe there are also medical regimens that can improve long-term durability. For example, there is an association between subclinical leaflet thrombosis and structural valve deterioration, right? So maybe if we can reduce the risk of subclinical leaflet thrombosis early on, we can also improve durability of the transcatheter heart valves. However, these are just hypotheses at this point in time. And
Yeah.
obviously, once we come to the point where we need to replace the transcatheter heart valve, we need to have strategies how to do this, right? And I
Mm,
think there's plenty of research to do this. We need to have safe strategies to maintain coronary access, to
mm.
mitigate the risk of coronary obstruction. We want to avoid patient prosthesis mismatch. All of these aspects are important, I guess.
Yes, absolutely. And thank you again, Dr. Pilgrim, for joining us today. And we invite everyone to go over the full manuscript published in this issue of JACC Interventions. Thank you again.
Perfect. Thanks a lot for having me.